Sekejap Okay, so ada few facts tentang stroke kan. Actually macam kalau kat Kuantan ni, you all tak dapat exposure tentang stroke service lah sebab HTAA pun tak aktif thrombolyze patient. Lepas tu dekat mana ni UIA pun tak ada lah sebab UIA tak ada neurologist. And basically macam bila you nak start stroke service ni, dia perlu good teamwork dan team yang rajin lah sebenarnya, sebab macam radiologist dia kena prepared, dia punya neurologist, physician pun kena prepared, MO dia pun kena aktif lah, ED dia pun kena aktif. So actually benda ni yang kita, maksudnya benda yang kita kena improve lah. Sekejap masih ada yang nak masuk. Okay. Tapi bila dalam exam kita kena tahu jugalah some facts, tapi dalam masa yang sama we should have aim actually untuk offer this service lah. Okay, so stroke ni leading cause of adult disability lah. And then for 1,000 patient that receive thrombolysis, a clot busting treatment, 80 will live more independently. So and then ada few population macam kat Malaysia, Indian, Malays, they likely to have a stroke kan. Susah sikit sebab I need to give a lecture tapi dalam masa sama saya kena jadi admin yang admit student masuk kan. Okay. So benefits of advance in stroke management ni, kalau kita so earlier recognition, better patient outcomes, shorter time in hospital and shorter periods of rehab. So decrease in recurrent stroke. So semua ni adalah aim kita when we are managing stroke patient. So lepas tu satu lagi, this is the reason lah kenapa kita jadi doktor kan. Tak boleh sebenarnya, tapi dalam medicine ni nanti you all pun final year, tapi you all akan jumpa juga, maksudnya dekat benda ni reality lah, maksudnya tak ramai yang actually bila you nak offer some service tu tak ramai yang nak ke depan. Actually people macam malas nak ada on call, malas nak bagi service. Sometimes you nak offer tapi your another teams tu macam tak nak offer kan. Tapi benda ni yang kita kena improve lah, maksudnya niat kita jadi doktor ni sebab apa sebenarnya. So stroke kalau kita cerita tu macam banyak lagi, masih panjang lagi perjalanan kat Malaysia ni. Dan especially macam dekat sometimes tempat tu ada neurologist pun sometimes tak start, tapi ada tempat yang macam dia ada passionate physician macam dekat Tawau, diorang tak ada neurologist pun tapi diorang start thrombolysis treatment. Okay, so kalau kita faham strokes ni dia macam a brain's version of heart attack lah. So kalau macam contoh TIA tu is just macam a minor macam maybe unstable angina macam tu kan, tapi kalau stroke tu is actually a brain version of heart attack. And then so kalau kita guna term cerebrovascular accident, it's not appropriate lah sebab stroke ni sepatutnya preventable and treatable. So ideally stroke should be referred as stroke and TIA. Sometimes people use CVE, cerebrovascular event. Okay. And then kenapa kita nak kena treat stroke kan? Kenapa kita perlu ada maksudnya thrombolysis treatment? Sebab untuk 1 minit 1.9 million kita ada loss of 1.9 million neurons. So macam selama ni orang kata time is brain kan, time is heart kan, tapi dalam masa sama time is also brain. Maksudnya, and even kalau macam cardiology, there are lots of options. Maksudnya kalau dia dah dapat MI, contohnya dia punya EF dah poor, you can still do a lot of other things. Maksudnya bagi dia ICD ke, implantable cardio, macam-macam option untuk cardio patient. Tapi stroke ni is actually very depressing disease. That's the reason kita kena ada lots more physician yang macam ada passion untuk buat thrombolysis treatment ni lah. Okay, so urgency is the key of treatment lah. And then most of the stroke is actually ischemic stroke, 85% lah. And then 50% is actually hemorrhagic stroke. Tapi exam akan keluar both. Sebab apa? Sebab hemorrhagic stroke pun you need to know sebab despite it's only 15% tapi higher mortality. Kalau you tengok patient-patient yang ada hemorrhagic stroke ni yang dia meninggal cepat lah. Maksudnya dia datang tu dengan bad complication. Stroke ni analogi dia macam pipe kan. So kalau you ada, orang kata apa, kalau pipe tu sumbat, it's actually macam ischemic stroke lah. Kalau pipe tu pecah, it's actually macam hemorrhagic stroke. Okay, and then blood, okay, so common sources of blood clot. Satu infarct kan, macam contoh kalau from the heart, kalau dia macam cardioembolic daripada atrial fibrillation. Large arteries macam secondary to carotid stenosis. That's why macam sometimes kita buat ultrasound Doppler sahaja tak cukup. Sometimes you kena buat transcranial ultrasound sebab sometimes stenosis tu inside the brain tu pun dah ada stenosis kan. And then small artery is actually macam lipohyalinosis kan dalam hypertension semua, so lacuna stroke. And then blood due to clotting disorder, sometimes patient ada APLS, so they have a clot lah yang causing all this thrombosis. And then blockage ni, okay tadi kita dah cerita kan, deep tiny arteries, lacuna stroke, cerebral embolism, and then okay, this is the causes lah. So what is thromboembolism? Blood clot that plugs an artery and blocks blood flow to a portion of the brain. How does it occur? It's actually mechanism yang tadi dah cerita juga, atrial fibrillation, so causing a cardioembolic kan. And then effective treatment is actually thrombolytic lah. And then stroke ni kita ada non-modifiable lah, macam contoh advanced age tak boleh nak, kalau makin tua tu memang ada risk kan. And then gender, race, family history lah. Tapi kita ada modifiable ischemic stroke risk factors. That's the reason kita kena treat kalau you pergi klinik kesihatan ke later on atau you pergi mana-mana pun. So you need to treat all these underlying conditions sebab you nak prevent morbidity dengan mortality kan. So so you kena treat hypertension, diabetic. Sometimes kita tak faham pun outcome kan. Kalau kita boleh manage diabetic, just nak continue. Jadi doktor yang continue plan, continue 3 bulan, continue 6 months tapi tak manage properly. It's actually kita tak perasan pun benda-benda yang kita buat dengan tak ihsan tu is actually causing outcome to the patient, long term run kan. So they develop complication of stroke. And then you need to advise lah, all this is actually non-modifiable, benda yang maksudnya this is your responsibilities as a doctor. Okay, kenapa kita nak treat ataupun thrombolyze kan? Satu, maaf, saya kat rumah sebenarnya, anak saya tengah mandi, bising ke?
Tak apa doktor, boleh dengar lagi semua doktor.
Boleh dengar Okay, so time is brain kan. Reason kita nak, bila dia ada infarct, so dia akan ada a core area ni is actually irreversible damage lah, maksudnya dia dah infarct kat situ. Tapi why you want to thrombolyze is actually you nak save the penumbra ni, a zone of reversible ischemia around the core, so that is salvageable. So reason kita nak treat ni sebab penumbra ni lah. Tapi kalau kita tak treat, penumbra ni makin besar and makin besar. So dia punya morbidity lagi besar kan. So benda ni kita nak kena treat. Kalau bising sangat beritahu saya kena lari tempat lain. Okay. So thrombolysis, okay. So you kena, nanti kita akan go through indication, contraindication of thrombolysis lah. So within, so time is brain, within 4.4 hours kan. So you need to nurse jugalah, macam ada patient yang macam wake up stroke. Wake up stroke ni macam Patient yang dia tidur, dia bangun tu tiba-tiba tangan dah lemah kan. So when is the onset tu is actually the last time patient was seen as a normal. Maksudnya bila dia last kali terakhir kita tengok dia normal sebelum dia tidur tu ke, atau dia mungkin ada terbangun tengah malam, dia okey je. Lepas tu pagi tu baru berlaku stroke. So the onset is actually the last time patient was seen normal lah. Okay. And then bila patient datang, you need to treat other condition. Maksudnya kalau dia datang dengan macam contoh MCA infarct, which hemorrhagic transformation kan, sometimes dia seizure kat situ, ataupun dia ada hyperglycemia, dia aspirated, you need to treat all this condition. Sebab benda ni all this concomitant condition akan worsen the penumbra. Okay. So important, you need to history, risk factor, CT scan, and then you need of course dalam stroke management you really need CT scan lah, sebab you nak differentiate between ischemia ataupun hemorrhagic. And then you need to rule out other stroke mimicker macam hypoglycemia, tumor, trauma, seizure ataupun migraine. So stroke ni macam tadi kita cerita large vessel, small vessel ni sebenarnya hypertension macam laku dalam stroke. Cardioembolic, hemorrhagic, it can be a intracerebral hemorrhage ataupun subarachnoid hemorrhage due to aneurysm ni semua. Okay, so there is a 5. Okay, benda yang susah tentang stroke ni untuk medical student ataupun untuk MO medical officer, selalunya dia nak localize stroke tu lah. Tapi kita cuba actually kita discuss benda ni kan. So ada few area yang you need to know is actually supratentorial area dengan infratentorial lah. Nama dia pun supra kan. Bila supratentorial ni is actually upper part. So and then you have the cerebellum area dengan brainstem lah. So dekat grey matter ni you ada cerebral cortex, and then dekat deep white matter ada cerebral subcortex, and then this is the you punya brainstem dengan cerebellum. So sebenarnya benda yang paling senang tu kalau macam you assess cerebellar stroke kan, macam you tahu cerebellar ni dia tak boleh dia mesti ada semua macam finding dia tu dia akan relevant. Dia macam contoh patient akan jalan, dia akan reeling towards one side, and then you tengok ada nystagmus, dysmetria, dysdiadochokinesia. So cerebellar macam senang. So bila you assess tu you dah boleh rule out dah cerebellar stroke. And then kalau cortex usually dia akan ada contralateral, maksudnya patient datang dengan hemiparesis over the right side, so you punya lesion is actually over the left side kan. Tapi macam kalau macam involvement of cranial nerve usually dekat brainstem. Tapi kalau macam antara cerebral cortex, brainstem dengan cerebellum ni tiga-tiga ni tak ada, sebenarnya cerebral subcortex lah. It was actually difficult sikit nak diagnose cerebral subcortex. Okay, so dia kata kat sini, in general terms, the supratentorial areas of the brain are responsible for the function of the contralateral side. Where the infratentorial areas such as cerebellum are responsible for the ipsilateral side of the body. That's why macam contoh bila you ada cerebellar stroke, maksudnya patient reeling towards the right side, so you tahu dia ipsilateral lah, dia mesti right cerebellar stroke. Tapi kalau dia datang dengan hemiparesis ataupun hemiplegic, you tahu the contralateral. But you need to remember about some things called as cross finding. Cross finding ni macam contohnya okay, contoh saya ada right hemiplegic, okay, and then saya ada right upper motor neuron CN7. So you tahu dia adalah lesion dia dekat left side, okay. But then kalau dia ada cross finding, maksudnya contoh dia ada right hemiplegia tapi dia ada right hemiplegia tapi dia ada left side dia tu is actually left upper motor neuron CN7 palsy. So dia macam ada orang kata apa contralateral kan, dia macam ada cross finding ni. So you need to think that the lesion is actually more towards the brainstem area lah. Okay. And then brainstem you usually ada midbrain, pons and medulla. So kalau cranial 3 and 4 affected is actually at the midbrain. Pons bila dia 5 to 8, medulla is actually 9 to 12 cranial nerve. And then aphasia kan, so most of your patient ni akan ada aphasia, so you need to detect whether it is actually broadcast ataupun Wernicke. So broadcast aphasia ni usually patient boleh cakap, dia punya comprehension, maksudnya dia faham dia apa yang dia nak cakap, tapi dia more ada macam dysarthria kan, dia rasa difficult untuk speak, so difficult to articulate benda tu. Tapi kalau macam ni dia sangat fluent, dia boleh cakap tapi memang word salad, maksudnya word salad ni macam dia cakap tu tak ada meaning ataupun dia mampu comprehension lah. So Wernicke dia adalah dominant posterior temporal, and then broadcast is actually at the dominant frontal. Okay. Bila you assess aphasia, you need to assess FCR ni lah, fluent, comprehends and repeats. Sometimes macam dalam exam about macam difficult lah kalau macam you go for short case, you nak assess semua ni, tapi this is actually the knowledge yang you kena ada. There is some things yang macam repeat ni actually kalau you tengok Wernicke tak boleh buat, broadcast pun tak boleh buat. Ada yang dia boleh buat fluent, dia comprehend, tapi dia punya problem dekat conduction, dia tak boleh nak repeat. It's actually conduction aphasia. I will show you one more image. So dekat sini kan, so kalau macam dia repetition ni dia tak boleh buat, it's actually dia affect dekat outward fasciculars ni. Okay, so this is broadcast, Wernicke dengan conduction. Dia ada banyak lagi lah, maksudnya area kan in the brain. Tapi yang important is actually broadcast dengan Wernicke ni untuk you tahu. Okay, and then stroke, sometimes macam contoh kalau you tengok patient stroke yang datang dengan MCA infarct kan, so dia akan ada macam vertical preference dia tu towards the affected area. Macam contoh dia punya infarct tu dekat left side, so dia punya left eye preference, dan dia akan neglect dia punya contralateral of dia punya body kan. So tadi left, so dia neglect dia punya right side. Okay. So benda ni pun important, nanti later ada lagi another slides. Sama ada dia middle cerebral artery, anterior cerebral artery ataupun posterior cerebral artery. So kalau posterior ni macam senang lah sebab dia akan affect you punya vision, so dia ada color anomia kan. Kalau middle dengan anterior ni is actually maksudnya kalau anterior cerebral artery, kalau you tengok foot and leg, contralateral monoparesis kan. And then tak apa, yang ni nanti ada yang simplified sikit. Okay, so contohnya, okay, this is contoh kan, kalau patient ada right hemiparesis, dia ada right visual field defect, deficit, right hemisensory loss, ada aphasia dengan left gaze preference kan. So macam left gaze deviation ni maksudnya mata dia ke kiri tu, you know, is affect the left hemisphere lah in a dominant right-handed individuals. And then brainstem ni sometimes dia ada benda ni yang kita cakap tadi, cross findings kan. Dia punya cross sign tu dekat right, muka affected dekat right side, tapi dekat dia punya orang kata apa, hemiparesis ataupun hemisensory loss dia tu dekat left side ataupun contralateral lah. So this is usually brainstem. Again, brainstem dia akan datang dengan typical cranial nerve involvement. So macam contoh, baru ni kita ada satu case dekat dalam ward, dengan pakcik tu pakcik Yamat, tak pasti ada yang jumpa ke tak kan. So pakcik ni datang dengan dysphagia, memang kena pakai rice tube, even dia aspirate dia punya own saliva. Lepas tu dalam masa yang sama, bila you assess patient ni dia tak ada pun plantar, downgoing, tapi dia ada ataxic, dia akan fall towards dia punya right side. Dia ada Horner syndrome over the contralateral side. So patient ni memang kita dah suspect brainstem dan kita suspect specific brainstem iaitu Wellenberg lah. So patient memang buat MRI ada infarct dekat lateral medullary, dia memang ada lateral medullary infarct lah. So ni brainstem. Cerebella macam tadi kita cerita memang senang je sebab cerebella ni kalau you tengok clinical signs memang dia ada ataxia, lepas tu nystagmus, dysmetria, dysdiadochokinesia. So kalau you dapat cerebella, it's actually very easy ataupun you akan cakap macam terus dia you tahu this is affecting posterior circulation stroke kan, POCI. Again this is the cranial nerve, maksudnya you boleh kalau affect 3 and 4 daripada midbrain, 5 to 8 pons, medulla 9 to 12. So symptoms that the patient can come pun benda ni. Okay, nanti I forward, boleh balik baca juga. Okay, bila you buat, maksudnya nanti you houseman kan. So kalau ditakdirkan you kerja dengan neurologist ataupun physician, usually apa yang diorang nak adalah you boleh describe sama ada patient ni adalah touchy, pachi, laci ataupun pochi lah. So tax, pax, lax ataupun pox. Okay, dia sama ada total anterior circulation stroke, partial anterior circulation stroke, lacuna syndrome ataupun posterior circulation syndrome. Okay, macam kita cakap tadi, paling senang sekali POCI. POCI memang you akan ada cranial nerve involvement, lepas tu dia boleh ada nystagmus, ataxia, vertigo. So semua ni adalah POCI. Sometimes senang je dia kata mata tak nampak. Dia datang tu macam memang kita boleh suspect terus ni POCI. Lepas tu ada 3 lagi iaitu touchy, pachi, laci kan. Kalau touchy ni dia memang affect 3 ni. Maksudnya dia akan ada unilateral weakness, dia ada homonymous hemianopia, dia ada higher cerebral dysfunction, dysphasia, visuospatial disorder. Kalau pachi ada 2 je of the following kan. Kalau lacuna stroke 1 je, maksudnya sama ada dia datang dengan pure sensory, pure motor, sensory motor ataupun ataxic hemiparesis. So benda ni yang paling important lah, maksudnya houseman to decide, okay, patient touchy ke. So touchy ni kalau dia datang condition ni very bad, maksudnya macam contohnya affect middle cerebral infarct kan. So memang patient backbound, datang aspirator, GCS drop, so very bad. Lacuna ni usually dia stable lah, tapi dia punya weakness tu kalau dia dapat pure motor memang terlantar juga, tapi dia punya GCS semua full. Partial anterior circulation stroke ni sometimes lebih kurang je macam lacuna, tapi dia macam ada homonymous hemianopia macam tu. Okay, so diagnosis in neurology case, what is the neurological deficit, lesion, what is the lesion, why has the lesion occurred, what are the potential complication and prognosis. So I believe you know at this point of time what is hemiparesis dengan hemiplegia. And then higher cerebral deficit ni macam contoh dalam kes ni bila you suruh dia lukis jam, patient memang ada neglect left sensory neglect, okay. And then ni contoh higher cerebral deficit, dia ada dysphasia, sensory neglect, dyspraxia dengan consciousness. Okay, homonymous hemianopia, blindness kan in the inner half of one visual field and the outer half of the other. Okay. And then brainstem usually dia datang dengan cranial nerve involvement. Ataxia dia boleh ada sebab cerebella, pons and medulla ataupun cervical cord lesion lah. Okay, ni yang tadi kita cerita tentang anterior circulation stroke. Usually anterior circulation stroke ni dia involve sama ada anterior cerebral artery ataupun middle cerebral artery. Anterior cerebral artery, the weakness of the lower limb ni more than upper limb kan. So you kena remember you punya homunculus. Okay, and then middle cerebral artery, this is the features lah. Kalau exam postgrad dia akan tanya parietal lobe dysfunction ya, sebab you kena assess macam mana you buat extradosis, graphesthesia, impact to point discrimination ni you kena assess. Dan selalunya macam neurosearch pun selalu practice parietal lobe dysfunction ni. Okay, ni anterior circulation stroke, kita ada bawah dia macam tadi itulah, tachi dengan pachi. Okay, and then posterior circulation stroke is actually vertebrovascular artery circulation kan. So dia ada homonymous, myopia, cortical blindness, diplopia, dysarthria, dysphagia, Horner's. Horner's ni semua features dalam Wallenberg. Lakuna selalunya macam tadi kita cerita laci, dia sebab hyalinosis tu dalam hypertension semua. So lipohyalinosis. So dia akan datang dengan pure motor atau pure sensory lah. Ataxic hemiparesis ataupun sensory motor stroke. Okay, contoh clinical scenarios of the strokes ni. Contohnya a 60-year-old man presents to casualty complaining of a sudden onset of a shake in his left hand. On examination, he has an impaired coordination in his left hand. So, you tahu sama ada dia ada dysmetria atau dysdiadochokinesia. So, lesion ni macam senang kan. So, dia adalah posterior circulation stroke cerebellar. Okay, one more thing, macam contoh kalau ada siapa-siapa yang pernah tengok Pakcik Ahmad tu, it's actually atypical kan. Macam bila you assess dia, dia tak ada no long track signs. Maksudnya dia tak ada plantar dia downgoing. So you tak jumpa benda lain. So memang pure posterior circulation stroke cerebellar. And then contoh second scenario, a 70-year-old man presents with difficulty speaking which came on suddenly 12 hours ago. On examination, he has an expressive dysphagia. So dia tak mention weakness ke tak ke kan, tapi sebab dia dah affect higher cerebral function, despite macam tadi kan kita cerita paci ni mesti 2 daripada 3 kan, tapi adik-adik masih follow ke? Okay, so kalau paci ni maksudnya dia sepatutnya 2 out of 3. Tapi whenever patient ada any higher cerebral dysfunction, even 1 pun, you tak boleh label dia as maksudnya kalau tengok ni, dia 1/3 je lah kan features yang dia ada. Tapi sebab dia dah ada one involvement of higher cerebral dysfunction, maksudnya dia ada expressive dysphagia, you still need to diagnose this patient as maksudnya paci. Sebab lakuna tak boleh ada higher cerebral deficit. Okay, scenario 3. An 80-year-old man presents to casualty after a collapse at home. On examination, he is unconscious and has a left hemiparesis. Okay. So yang ni kalau tengok dia macam paci kan sebab left hemiparesis, dan dia dah affect dia punya higher cerebral dysfunction sebab unconscious. Tapi ada satu yang tak adalah, cuma kalau dalam patient yang unconscious, kita kena assume dia ada hemianopia. So that's the reason kita label dia as tachi. Okay? Faham ke adik-adik setakat ni ke confused?
Faham doktor.
Faham so benda ni yang difficult sikit sebab tadi macam kenapa kita cakap benda ni paci, kenapa bukan, you kena faham kenapa dia bukan laci. So macam dalam kes ni sebab dia ada expressive dysphagia. Once dia ada any higher cerebral higher deficit, maksudnya high cerebral dysfunction ni, maksudnya contohnya expressive dysphagia, you need to label as paci. Okay, so yang ni you kena cakap dia tachi, okay, sebab despite you nampak macam ada 2 je features, tapi kenapa kita cakap dia tachi? Sebab dalam patient yang unconscious kita kena assume dia ada hemianopia, so dia akan jadi tachi. So tachi ni memang dia datang tu very bad. Sorry, tak tahu kenapa dia laju sendiri. Okay, and then scenario 4, 50-year-old woman complaining of visual disturbance. So on examination, she has a right homonymous hemianopia kan. So vision ni pun macam senang juga. Kalau any vision ni macam you dah boleh suspect mesti posterior circulation stroke. Okay, sebab dia datang tu satu je benda kan. Visual disturbance ni usually associated dengan occipital infarct lah, posterior circulation stroke. And then this is another example. A 65-year-old man is brought to casualty by his wife. He has been behaving strangely for the past 2 days. On examination, he has shaved only the right half of his face. His visual fields are intact. So macam patient ni, you tahu dia ada features dia cuma cakap satu je, neglect kan? Betul tak? Tapi dia dalam senario ni dia tak mention pun patient ada left hemiparesis ke. Cuma satu je, tapi sebab dia affect higher cerebral deficit, again dia adalah, you tak boleh cakap dia lacuna stroke. Kan dia cuma ada satu je features yang dia mention dalam ni. Tapi sebab dia affect higher cerebral deficit, you need to mention partial anterior circulation stroke. Okay, and then scenario 6, a 50-year-old woman presents to her GP with weakness in her right arm. On examination, she has impaired coordination in her right arm and leg. Okay, kalau kita baca sampai sini, kita rasa dia macam poci kan, maksudnya cerebellar stroke, betul tak? Dia ada impaired coordination. Tapi bila further history, bila you assess lagi, dia ada brace reflex and upgoing plantar on the same side. So dalam condition sini, is actually ataxic hemiparesis dalam lacuna stroke. Kenapa kita tak cakap dia poci? Sebab dia ada long track signs. Long track signs ni brace reflex dia, upgoing plantar kan. So this is long track signs. Tapi patient ni ada tak impact dia punya higher cerebral dysfunction, dia tak mention. Dia ada tak homonymous hemianopia, tak ada juga. So dia ada one je features, tapi you need to differentiate whether this is laci ataupun poci sebab ada impact coordination ni. Tapi kalau poci dia tak boleh ada long track signs ni. So that's the reason kita diagnose patient ni as lacuna stroke. Faham ke adik-adik?
Faham tak?
Faham tak saya?
Kalau tak faham tanya. Okay, scenario 7. A 60-year-old man presents with sudden onset of weakness in his right arm and leg. On examination, he has a right hemiparesis. A CT brain was done 24 hours after the onset of symptoms and was reported as normal. Okay, where is the lesion? Okay, again, this is lacuna stroke kan, sebab dia datang right hemiparesis ni, dia bukan hemisensory, dia hemiparesis pure motor stroke. Dia tak mention pasal homonymous hemianopia. Dia tak mention juga patient ada higher cerebral dysfunction, higher cerebral deficit, dan dia cakap CT brain dia normal. Sebab lacuna stroke ni is actually macam memang small stroke, one dot je kadang kan, tapi dia punya effect kadang besar lah, maksudnya macam dalam kes ni pure motor stroke. Okay, tapi dia tak affect dia punya higher cerebral dysfunction, dia tak ada homonymous hemianopia. So patient ni adalah lacuna stroke. Okay, scenario 8. A 40-year-old woman presents with weakness in her right arm. She has a spastic weakness in that arm but no neurological signs in the other limbs. Okay, ni dia cuma affect tangan dia sahaja. Kaki pun dia tak mention. Okay, where is the lesion? So monoparesis adalah termasuk dalam partial anterior circulation stroke, PACI. Okay. Okay, scenario 9, a 90-year-old man presents with weakness in his right arm and leg. On examination, he has grade 1/5 power on the right side of his body and has an expressive dysphasia. So kita tahu dia dah affect higher cerebral dysfunction. Kita tengok dia dah ada, maksudnya dia punya higher cerebral dysfunction dengan dia ada hemiparesis kan, hemiplegia, 1/5 over right side of his body, witness dengan higher cerebral deficit, so partial anterior circulation stroke. The only things yang dia tak ada kat sini yang diorang tak mention adalah dia tak ada homonymous hemianopia. Scenario 10, a 63-year-old man presents with a sudden onset of hiccups, nausea, vertigo and difficulty walking. On examination, he has a right-sided Horner syndrome, nystagmus and ataxia on the left. There is also loss of pain and temperature sensation of the left side of the face. Ini sebiji macam pakcik Yamat. Tapi ni dia rare tapi you need to know. Tapi kalau you baca pun maksudnya you perasan dia tak ada lots of macam cranial nerve involvement. Lepas tu you tahu macam hiccups ni is also a features in a Pochi stroke. And then dia punya nystagmus dia akan towards the affected area kan, so left area. And then dekat left side of the body pun ipsilateral, loss of pain and temperature sensation. So this is actually Pochi brainstem. Usually patient ni mana kena pakai rice tube. Benda ni juga yang dia cakap kan, satu cross finding, dia happen on both sides, suggest brainstem. And Wellenberg's ni is actually good for you to know. It's actually dorsolateral infarction of in the medulla. Dan specific artery yang affected adalah PICA, posterior inferior cerebellar artery. So hopefully you learn from all that 10 scenario. Okay. Cerebellar stroke, benda ni yang macam masa case Pakcik Ahmad tu, CT brain dia normal, but when I request MRI tu, it was rejected. From the beginning tu macam masa tu terus rejected by radiologist kan. But one day kalau you become a radiologist, you shouldn't macam refuse lah kalau macam patient yang suspected cerebellar stroke. Sebab sometimes CT you tak pick up. And then usually macam all these Pochi, they can, brain kita ni is actually dia tak boleh nak kembang lagi kan. Usually so because of the edema tu patient akan makin teruk cepat lah. So they need a surgical decompression. So this is pathophysiology of lacuna ni, you need to remember the keywords lipohyalinosis sebab DM hypertension. Okay. And then sometimes dia boleh ada internuclear ophthalmoplegia. Okay. Ni yang tadi kita cerita pasal Wellenberg, lateral medullary syndrome, famous exam question, tapi sebenarnya rare occurrence dia lah. So kalau you ada satu case yang you jumpa tu, you akan remember for the rest of your life lah features dia. Okay, tadi kan kita cakap one more things that is macam you need to know about internuclear ophthalmoplegia. Sebab kalau old, sometimes dia akan datang dengan satu je features ni, you need to think lacuna stroke boleh ada. Tapi kalau young patient datang dengan internuclear ophthalmoplegia, so you need to think about MS, multiple sclerosis. So apa yang you macam ni internuclear ophthalmoplegia ni, this is the baseline of the eye lah, maksudnya dekat central. Then you ask the patient to move to one side, dia patut move. Tapi bila you ask and then when you benda ni, bila you ask macam dalam case ni kan, internuclear ophthalmoplegia INO dia ni dekat right side lah, sebab you ask the patient to move to the left, yang left eye ni move, tapi right side dia medial rectus dia affected kan. Tapi you need to differentiate bila dalam kes internuclear ophthalmoplegia, is it third nerve palsy ke ataupun higher lesion macam lakunan stroke ke tak. So you tengok ni macam ada features of internuclear ophthalmoplegia. The next step that you need to do is actually you ask the patient untuk tengok accommodation. Kalau dia boleh accommodate, basically dia punya third nerve tu intact. So it is actually higher lesion lah. Sama ada kalau young patient tadi you kena think about MS. Kalau old patient you think about lakunan stroke. Okay, and then we already finished dengan ischemic stroke. And then the next is actually intracerebral hemorrhage. So it can happen because of bleeding abnormalities, tumor, ruptured blood vessel ataupun arteriovenous malformation. I remember one case, actually pakcik ni Chinese, lepas tu dia datang tu fitting dia actually biasa lah kan. Benda ni yang sebenarnya kita kena ubah lah. Habit ni actually untuk tengok continue the same. Maksudnya kalau one day you dekat klinik, continue the same kan. Saya banyak kali je kena benda ni. So patient ni dia datang tu, tapi bila saya tanya tu dia dah macam 4 anti-epileptic tapi seizure dia still tak control. And then I ask the patient actually bila tengok balik go through, dia tak pernah buat MRI semua. So pakcik ni willingly buat MRI dekat private and then diagnose dia ada AVM lah. But he goes for op and he died masa op tu. And then I got few more patient yang macam kita nak continue the same tapi it's actually macam label as stroke tapi sebenarnya patient ada motor neuron disease. So habit untuk continue the same ni kita kena tukar lah. We must be interested dengan patient kita dan kena tengok balik. Okay, and then subarachnoid hemorrhage ni, kalau you remember masa you undergrad kan, kalau you pergi lab tu dia ada brain model tu. So macam kalau you tuang macam contoh kopi ke atas brain model tu, so semua tu macam spread kan. So subarachnoid hemorrhage ni macam itulah, dia affect dekat gairah you kan. So it can happen because of bleeding abnormalities, tumor, rupture of an aneurysm or vessel malformation. It was actually very difficult untuk you differentiate sama ada it is ischemic ataupun hemorrhagic. Tapi there are features to suggest it can be macam maksudnya hemorrhagic when the patient dia ada features ni lah, headache, nausea, vomiting. Sebab usually macam ischemic stroke ni jarang patient tak datang dengan headache lah. And then decreased level of consciousness, intolerance to light, neck stiffness sebab subarachnoid hemorrhage. Okay. One more things yang you need to remember adalah seizure. One of the differential, ramai yang suka macam kalau lah dia macam seizure, macam contoh city brain dia tak, macam contoh seizure ni occur dalam macam patient yang macam MCA, infarct, hemorrhagic transformation. Kalau you tengok CT tu memang lesion dia besar sangat kan. Maksudnya you boleh nampak lah kalau dia dah sampai dia nak seizure tu. Tapi kalau you tengok dia city brain dia normal tapi patient ni fitting kan. So you need to think one more differential. It is not arterial tapi it's actually venous infarct. Cerebral venous thrombosis. So kalau you dekat klinik kesihatan misalnya, pregnant lady ataupun postpartum patient datang tiba-tiba fitting tu, you punya first actually macam differential you adalah venous thrombosis. Benda ni banyak kali berlaku maternal mortality kan, sebab venous thrombosis ni kadang dia macam bleed tapi the treatment is actually you still need to give anticoagulant. So benda yang okay. So intracerebral hemorrhage dia boleh ada ICH, SAH, epidural hematoma or subdural hematoma. Kalau surgical management, so this is how you treat bleeding lah, aggressively treat, BP kena bring down and then coagulopathy pun kena treat. subarachnoid hemorrhage, usually macam tadi kita explain, and features yang selalunya patient datang tu dia adalah worst headache. Lepas tu you must remember sometimes subarachnoid hemorrhage ni 85 to 90% je pick up by CT. So LP boleh pick up more than 95%. Dia ada satu features dekat LP yang satu features yang saya lupa apa nama dia. Siapa ingat tak? LP dalam subarachnoid hemorrhage yang kita akan nampak. Siapa ingat?
Tak ingat doktor.
Xanthochromia. Okay, so kalau ada xanthochromia tu dia highly suspicious of SAH. Okay, angiogram is a gold standard. Okay, and then subdural dengan epidural hematoma ni I believe you learn more in surgical lah. Crescent shape, biconvex, benda-benda ni kan. Hemorrhagic stroke tadi causes dia boleh jadi amyloid, coagulopathy, tumor. One more things is actually dalam subarachnoid hemorrhage is actually causes dia adalah mycotic aneurysm. I have one patient, dia datang dengan IE, infective endocarditis. Lepas tu patient ni masa COVID hari tu meninggal kan, umur dia 35 tahun, young mother, dia ada 2 orang anak. Patient ni actually husband dia cakap tiba-tiba boleh cakap sabahan, tapi HTA kata tak ada, normal je patient delirium sebab IE tu kan. So masa tu kita buat contrasted CT, reported as calcification, tapi patient pergi HD, meninggal kan. One benda yang you need to remember juga mycotic aneurysm ni kan, dia sebab septic emboli. So dia sangat vessel tu is actually very fragile, so easily bleed. So patient ni meninggal dunia. Okay, what investigation you would like to do kan? So this is actually kalau you dapat dalam long case, I'm expecting macam you boleh mention benda ni. And sometimes bila you dapat long case atau short case stroke, you yang macam you just macam sebut je apa yang you nak buat. Full blood count. You jangan tunggu examiner tanya apa yang you nak tengok dalam FBC, apa yang you nak tengok dalam platelet, apa yang you nak tengok dalam white cell count. Tak, you need to offer you punya just stop and then gain as much point as you wanna dalam exam tu kan. So polycythemia, hyperviscosity, sebab polycythemia is one of the causes of stroke juga. Platelet disorders, bleeding, thrombocytosis, white cell count high, aspiration, pneumonia, cerebral abscess, and then ESR, kenapa you nak tengok. Lepas tu RP, target organ involvement, so fasting lipid, PTA, PTT, okay, thrombophilia, benda-benda ni is actually untuk kalau you suspect secondary causes. Okay, and then chest x-ray, ECG, echo, kenapa you nak buat ECG kalau you nak tengok paling important atrial fibrillation, sebab you need to treat the underlying, maksudnya cardioembolic kan. Okay, lepas tu carotid ultrasound Doppler. CT scan is actually because you want to okay, usually stroke ni is actually clinical diagnosis lah, sebab even earlier you buat ultrasound early tu pun you tak nampak ada apa ni, tak nampak anything, tapi you want to do CT scan ni sebab you nak differentiate between ischemic ataupun hemorrhagic. Okay, lepas tu MRI more sensitive dalam brainstem involvement. Okay, I will show you later a bit on CT interpretation kan. Okay, so macam bila you assess CT ni, okay, ada benda je lah yang you kena tahu. Kalau macam ni you berminat dengan radio lah. So clot berapa, HU dia, classification. Benda ni is a bit detail for you all. Tapi basically kalau you nak access bleeds, easier dalam brain window dan ischemia window. And then so scroll the image tu, you need to divide the image into 4 quadrants. And then intracerebral hemorrhage, the bright area measures 60 to 70 HU. So tak adalah nak suruh you pick up benda-benda HU ni, dah sangat detail lah. So tapi basically kalau you tengok macam bright area tu, you suspect bleed. So subarachnoid hemorrhage, benda yang akan affect dalam gairah you kan. Sometimes you need to, a bit difficult untuk differentiate between sama ada benda ni artifact ke tak. So that's the reason sometimes radiologist akan guna HU tu lah untuk looks whether it's a blood ataupun kalau dekat basal ganglia ni usually calcification kan. So HU dia more than 100, kalau blood ni more than 60, less than 100. So this one is actually used by the radiologist. And then okay, ni big details lah. Okay, so bila buka CT tu, you need to know anterior cerebral artery area, PCA dengan MCA area. Lepas tu reason CT ni important is actually sebab sebab masa you nak kira untuk kan when you want to decide actually regarding thrombolysis, you need to calculate NIHH score tu. Dengan satu lagi, you need to calculate aspect score lah. So, okay, this is aspect score lah. Aspect score ni dia 10, markah dia bermula dengan 10. So, each area yang affected, maksudnya dia ada 10 area. So, satu CI, maksudnya caudate satu, insula satu, internal capsule satu, lentiform nuclear satu, dan dia ada cortical regions yang di cover ni ada 6. So total 10 lah. And then you need, kalau macam ada area yang tak normal tu, you need to minus 1, minus 1, minus 1. So less than 8 is actually contraindication untuk thrombolysis. So aspect score ni good to know jugalah. Okay. Okay. So yang ni macam dia bagi you analogi lah. Maksudnya bila you buka CT tu, you kena sampai dekat area yang macam nampak macam frogs ni. Lepas tu so this is actually macam you boleh imagine you punya anatomical maksudnya mid cerebral artery ni represented by the arms of the frog kan. Okay. Lepas tu laju sikit sebab benda ni sangat detail. So ni pun a bit difficult sebab you kena bezakan healthy insula dengan damaged insula. Lepas tu you scroll sampailah you nampak insula ribbon ni kan. Bila you nak tengok CT, lepas tu internal capsule ni is actually something yang looks like boomerang ni. So kalau macam you tengok ni, boomerang ni nampak je kan, tapi dekat sini macam boomerang dia macam affected. Lepas tu basal ganglia ni between the internal capsule dengan insular ribbon. So ni insular ribbon you, and then this is internal capsule, so basal ganglia ni in between tu. So usually kalau kat sini you akan nampak calcification lah. Okay, yang ni nanti you boleh baca. We just want you to know the anatomy a bit. Okay, importance of interpretation of CT scan ni sebab aspect score tadi. Okay, in terms of management, So this is actually an indication. I will forward, nanti saya akan bagi you all jugalah benda ni. So eligibility inclusion criteria untuk thrombolysis, age over 18 years old. Lepas tu history dia konsisten dengan ischemic stroke. Time onset tu maksudnya below than 4.5 hours lah. So kalau earlier lagi better, and then kalau 3 to 4.5 hours ni, this is actually inclusion criteria. Maksudnya NIHSS score dia less than 25, MC infarct less than 1/3 kan. So macam tadi kita bincang exclusion criteria, mesti kena measure aspect score tu less than 8. Infarct size dia kalau more than 1/3 memang kena exclude lah untuk thrombolysis. Lepas tu CT scan dia pernah ada cerebral hemorrhage, anything contraindication. Kalau you suspect subarachnoid hemorrhage is also contraindication. Kenapa you suspect? Patient datang dengan CT brain normal je, tapi dia datang dengan worse headache. You tak rasa infarct, ischemic infarct usually patient tak datang pun dengan headache kan. So worse headache ni you suspect subarachnoid hemorrhage. So you exclude patient ni daripada thrombolysis. And then dia ada head trauma, hypo ataupun hyperglycemia. Sometimes benda ni macam relative contraindication lah. Usually once you dah stabilize, sometimes you still go. Reason dia hypo ni, you takut stroke mimic lah. So kalau you dah treat tu macam still nampak dia macam stroke juga. So benda ni macam relative, sama ada you nak thrombolyze ataupun tak. Okay, and then BP pun you kena, kalau you nak thrombolyze, kalau you tak thrombolyze, you accept BP 220-120. Kalau you nak thrombolyze, you kena bring down the BP lah. So this is the reason nanti kita akan bagi IV labetalol kat patient. Okay. Kenapa kita BP high dalam apa ni? Kita keep BP high untuk patient yang ada infarct ni, sebab you want sebab it is actually a mechanism. Maksudnya dia counter, dia nak save the penumbra. The area tu sometimes memang BP dia high. So you bring down the BP, you akan cause more damage to the penumbra. Tapi untuk you thrombolyze, you need to bring down at least below 185, 110 ni. So these are the exclusion criteria. Okay, this is how you discuss with the family member. You need to explain the benefit. Okay, no clear benefit seen at day 1, but 30% more likely to have minimal or no disability at 3 months. So improvement of the maksudnya disability tu lah. Sometimes memang dia dah datang tu, dia dah ada macam disability, tapi reason you thrombolyze juga is actually you doesn't want the current disability tu to worsen, and sometimes disability tu you boleh reversible juga. Okay, and then you need to explain about the risk intracranial hemorrhage. Okay, so you need to know that you are using altiplase untuk thrombolyze. Benda ni nanti I bagi you lah. Okay, non-thrombolytic patient, you need to give low oxygen. Maksudnya tak perlu pun bagi high flow mask, sebab dia orang kata from the recent evidence, dia kata high flow oxygen ataupun high oxygen causing worsening of the penumbra. So sometimes low oxygen je to maintain, kalau tak perlu, tak perlu. And then give hydration. Head positioning ni dia kata 15 to 30% untuk prevent aspiration. Feeding, rice tube, BP management. Okay, BP ni kita allow sampai 220-120. Ada yang start antihypertensive after 72 hours, ada yang start after 2 weeks lah. So yang tu ada few evidence lah. Tapi you tak boleh start kalau macam you tahu patient ni is contraindicated untuk thrombolyze and you are not going to thrombolyze that patient for 72 hours, please don't macam jangan kacau lah BP yang high tu. Okay, so medication, aspirin, statin, And then okay, this one is dalam TIA lah. Okay, yang dalam ni kan IST, CAS ni semua is actually trial evidence. You can read more lah kalau you interested. So dalam TIA chance trial lah. So chance trial ni dia kata kalau macam minor ischemic stroke ataupun high risk TIA kan, ABCD score dia more than 4, you bagi dual antiplatelet for at least 21 days. Okay, you can up until 90 days lah. So it was proven lah untuk reduce risk of stroke or recurrent stroke. Okay, and then bila patient dah masuk dalam ward, make sure bagi DVT prophylaxis. And then kalau patient ada atrial fibrillation, when you are going to start anticoagulant, so this is the magic number 1, 3, 6, 12. So kalau TIA, 1 day after acute event. Kalau mild stroke, 3 days after acute event. Moderate stroke, 6 days. Kalau dia severe stroke, maksudnya datang dengan middle cerebral artery infarct, ada hemorrhagic transformation. So bila you nak start anticoagulant untuk patient ni, at least 12 days after the acute event. So sometimes kalau dia ada hemorrhagic transformation, you need to assess at day 12 before you decide to start anticoagulant. Okay. Saya rasa tu je. Ada apa-apa soalan ke nak tanya ke?
Dr. Ummu, my name is Arif. For the patient that have complicated with hemorrhagic transformation, the treatment tu has become the same as hemorrhagic stroke ke, or dia tak payah macam surgery ke?
Kalau dalam MCA infarct, you still need to ask you punya kena refer patient ni kat neurosurgical juga, sebab sometimes dia akan buat decompression juga, sebab bila dia dah ada middle cerebral artery infarct hemorrhagic transformation, sometimes dia akan push away, maksudnya dia memang ada orang kata apa, edematous tu you need to refer neurosurg. Kalau tu you stop dulu anticoagulant dia, hemorrhagic transformation. So tapi anticoagulant decision tu yang tadi 12 days tu. So you assess dulu ada worsening ke tak, lepas tu baru you decide untuk start oral anticoagulant.
Maksudnya for hemorrhagic transformation, it is not, tak semestinya kena surgery lah doktor, tak semestinya kena decompression. Tak
sebenarnya, you punya yang akan decide, tapi you as a physician, maksudnya as medical tu, you kena refer awal patient yang you dah suspect MCA infarct. Jangan tunggu sampai drop GCS semua kan. Tapi biasalah MO neurosurg akan cakap patient okey je lagi kan, GCS okey lagi, monitor GCS macam tu. Tapi you as a primary, you dah suspect patient ni MCA infarct, you tengok macam from the clinical examination dah macam touchy kan. Maksudnya memang datang dah, kalau unconscious tu semua dah the need of urgent referral to neurosurg lah sebenarnya. Sometimes a good neurosurg dia admit ward dia, tapi sometimes macam itulah. Tapi you akan belajar benda ni masa you houseman kan. Life experience macam quality you. Macam itulah.
Doktor cakap macam MCA infarct kalau hemorrhagic transformation tak boleh dekat tempat lain ke doktor? Dia maksudnya?
Usually hemorrhagic transformation ni associated dengan MCA infarct.
Okay,
Lacuna tak ada, tempat lain tak ada.
Alright, thank you doktor.
Tapi differential, kalau macam saya cakap tadi, kalau dia nampak bleed, one thing is actually cerebrovenous thrombosis lah. Tapi usually dia, beza dia orang is actually CVT ni tak nampak sangat features dia. Dia punya CT brain tu very subtle, macam dia ada anti-delta sign, very subtle. Tapi you suspect from the clinical history itself. Macam contoh, patient yang postpartum, high risk untuk develop thrombosis. So dia datang tiba-tiba seizure, tapi buat CT macam tak explain. So dalam kes macam ni you need central venogram lah, CT venogram untuk assess whether it is actually venous thrombosis. Yang penting masa you all ni, saya rasa macam you know something about aspect score. Lepas tu you know indication, dengan satu lagi localization tu lah. Yang ni. Sebab benda ni masa you jadi houseman tu, physician akan tanya you lah. Is it touchy, pachi, laci ataupun poci? Macam tu.
Doktor,
Mm-mm.
yang regarding between MCA dengan PCA, dia ada talking about hormonal immunotherapy tu macam difference into macular sparing. Maksudnya macam mana kita nak cari benda tu on physical examination
Physical examination.
yang tentang macular sparing in the MCA tapi dalam PCA tak ada macular sparing tu.
Kita tak assess macular sparing. Maksud awak macam mana nak assess
Maksudnya kita confirm yang ada macular sparing or not tu. Ada apa-apa findings ke on physical examination? Ke maksud macular sparing in PCA tu maksudnya patient really doesn't see ke, maksudnya macam mana?
Kejap, saya kena buka satu. Sekejap Dia ada satu good NIHHS booklet. So benda ni one step by step tu, how you examine the patient tu dalam booklet ni ada. So kejap, I email dan buka tunjuk kat you all. Okay. Ada satu benda yang maybe I tak mention in detail. It's actually you need to know is bukan semudah macam macam ni kan. Okay. This is actually a form of NIHSS score. Okay, so you ada 11 item. So you pun macam tanda tick je kan. Okay, gaze normal, horizontal, partial gaze, complete gaze kan. Tapi sebenarnya visual field, dia ada no visual field defect atau ada partial hemianopia, complete hemianopia ataupun bilateral hemianopia. There is one things yang actually important juga is actually to be trained to assess NIHSS score ni lah. So later I forward kat you. So sebenarnya each component tu ada cara macam ni you nak assess lah, macam ni level of consciousness ni. Macam tadi kalau kita tengok ni very macam benda ni kan macam very superficial kan. Alert ni apa, drowsy ni apa, obtunded apa beza obtunded dengan drowsy, koma macam mana kan, orientation macam ni kita nak tanya orientation, answers both correctly ni kan. So dia sebenarnya ada booklet dia lah. So benda ni perlu training. So dalam, kalau macam contoh dalam so kalau it's actually kalau visual tu, you need to assess visual field you, apa dengan lower quadrants. So then only you assess macam patient ni ada partial ke, complete ke, bilateral hemianopia. So yang tadi macular sparing tu I'm not really sure, tapi this is how you assess apa ni hemianopia ni lah, maksudnya dengan you assess visual field, confrontation, benda-benda yang you belajar dalam cranial nerve masa you assess eye assessment tu. Gaze memang dia akan macam contoh, memang you tengok pun clinically you dah boleh assess dah patient ni ada preference kan, right ataupun left gaze preference. Tapi each component ni you perlu belajar. Maksudnya kalau motor arm ni apa yang you cakap 0, 1, 2, 3, 4, ada tu yang 5A, 5B, benda-benda ni. Facial palsy ni apa minor paralysis, apa partial paralysis. Each and NIHS score ni pun perlu detail lah sebenarnya.
Faham? Thank you, Doktor.
Benda yang I rasa lah kan important untuk you bawa balik, untuk you survive you punya housemanship is Bamford stroke classification ni lah. Sebab macam masa you houseman tu, decision untuk thrombolyze ni semua maksudnya yang kena run everything. Kalau you pergi thrombolyze stroke pun, it's actually memang you punya MO lah yang kena decide kan, MO ataupun physician. Tapi the least kalau you pergi yang tak offer thrombolysis treatment tu, you punya physician expect you ataupun neurologist yang buat stroke round tu memang expect you tahu ni tachi, ni pachi, laci ataupun pochi. Lepas tu dalam exam question yang dia stroke localization tu pun sama dengan clinical scenario yang kita discuss 10 ni. So exam akan tanya you benda ni juga. So kalau macam dalam exam, kalau dalam short case ataupun long case, maksudnya you dapat neuro examination, as long as you dapat mention, maksudnya patient ni you tengok macam patient boleh obey command, lepas tu you just assess dia punya verbal kejap sikit kan. Lepas tu you tahu pakcik boleh cakap, so you rasa macam pure lacuna, you just can mention I think this is pure lacuna stroke. You boleh assess macam tak ada eye preference, dia punya visual field okay semua, so you boleh cakap je this is pure lacuna stroke. And then kalau you tengok patient memang tak boleh bercakap, macam memang ada dysarthria, lepas tu memang kena pakai RAS tube, you rasa this is actually macam total anterior circulation stroke. And then it is actually good enough lah kalau you boleh mention benda tu. So 10, I think nanti slide ni saya forward kan. So balik macam go through balik all these 10 scenario and be familiarized dengan stroke syndrome ni lah, maksudnya pochi macam mana, benda tu. Macam yang ni semua macam very detail lah kan, transcortical. Tapi as long as you know it's broadcast dengan Wernix, good enough macam tu. So dia ada benda yang you kena tahu, ada yang you tak perlu tahulah sebenarnya. Ada yang detail juga dalam ni. Okay. Kalau tak apa-apa, kita tangguh dulu boleh? Okay, kita tangguh dengan tasbihah Faradan Sultan As.
Thank you, Doctor.
Okay, thanks.
Thank you,
Doctor,
Doctor.
actually we are recording the session, so I would like to ask permission if we have a YouTube